Hi, I'm Dr. James Forest-Lam. I've been practicing in the field of emergency medicine and internal medicine for quite a few years. I am board certified in both emergency medicine and internal medicine. I have been certified and recertified a total of 6 times in both fields together. Um, I want to share some of the experience in my practice and also what the in the process of studying for the examination and maybe highlight some of the topics questions that the boards deem important to be put on a test. A few words of introduction of myself. I went to University of California at Berkeley for undergrad. I then went on to get my master's degree in biochemistry at the Medical College of Virginia. Then I went to medical school in Virginia. And after that, I went to Brown for residency training program in internal medicine. And after that, I went to I took on a teaching position at Yale University, Yale New Haven Hospital at uh, New Haven, Connecticut. Uh, it's there that I recall uh, developing an interest in emergency medicine because I realized that I like the adrenaline that comes with seeing patients in acute care in the ER. Um, seeing somebody who got shot in the chest with requiring chest tube or a pneumothorax, or somebody who's in respiratory failure requiring intubation, or seeing somebody who has an obvious chest pain, ST elevation, and you just get your blood pumping. Want to send this guy to a cath lab or bring out the clotbusters or just just things that really get your adrenaline pumping. But that's part of my experience, and I want to pass on that to any colleagues that are getting ready to take the recertification examination or certification for the first time, or residents that are doing the same, or just anybody who's interested in medicine. If you're a PA, get ready to take your certification exam. Hopefully, this will be would help uh, add coloring to your test results. And also anybody who's a nurse who want to learn more about medicine. There are a lot of people that want to be better at seeing patients and have more knowledge than what they learn at school. And then patients who know the disease processes and learn how to treat their own blood pressure. Um, it's today we're going to talk about blood pressure, and I want to encourage people to realize that the treatment of blood pressure is very rewarding, and it helps you reduce strokes, reduce heart attacks, reduce heart failure, and reduce the chance of um, requiring dialysis or other disease complications from hypertension. Somebody once compared emergency medicine to internal medicine, where internal medicine is very in depth. Emergency medicine is very wide breadth in its field. Emergency medicine can be anything we kind of talked about before: trauma, uh, intubation, uh, quickly get somebody to the cath lab, or internal medicine, knowing which which disease is rheumatological disease, which one isn't, and therefore can really be helpful in identifying the disease entities. Some of these uh, vascularities can be is often seen in the emergency room. I, for example, leukocytoclastic vasculitis. That is a disease entity that shows up in the emergency room with painful purplish lesions, and haven't seen it in the past. I was able to quickly uh, put somebody on prednisone, and and she got better the following day. She was taking uh, Bactrim several days prior to that, and then broke out in painful purplish, what I believe was leukocytoclastic vasculitis. That was very rewarding. So emergency and internal medicine, they kind of cross paths, and in ways that are very, very interesting. Um, and I once saw a case of silicosis, taking good history from a lady who was taking care of a sick pigeon, high fever, uh, uh, pneumonia symptoms, and she was treated with I believe it was doxycycline, and she got better. That was very. Without that, she may, if she was taking was given penicillin, she probably would have gotten better. But having that history, treating her with I believe it was a IV doxycycline, that was very rewarding, because that was a once in a lifetime gift that was somebody get to be able to see that. It's very gratifying. So hypertension. What can I say about hypertension? It's a disease of its own. It's a very prevalent, and I don't know why it exists, but it's a worldwide. It's a very, very common illness, and its presentation is very, very different in various different communities. Um, Having seen patients in San Francisco, one of the etiological identified etiologies include playing mahjong, extremely exciting um, uh, game of a domino, like a game, which I know, which I wouldn't mind learning how to play. Um, and when the players get very excited, and it's oftentimes that they develop a hemorrhagic, hypertensive hemorrhagic uh, inter, cerebral bleed, intracranial bleed, and and the diet also is contributing to hypertension due to a lot of a lot of high salt content diet also seem to affect many people. About 30% of the population has hypertension, um, and it's associated with aging and also with obesity. Um, so as we expect our population to age and obesity to be continue to be an issue, we're likely to see hypertension at, as obesity and aging continue to be an issue in our population. We expect hypertension to also be increasing in prevalence. However, here's the good news. Treatment of hypertension is a very rewarding um, undertaking. Uh, Reduction of hypertension, in, normalizing blood pressure, can reduce the morbidity and mortality from uh, stemming from hypertension, and reducing the incidences of strokes, ESRD, MIs, heart failure. Okay, the magic number, I'm gonna ring some magic number here. 140 over 90. Of course, that's the number that above which, if you document it twice, in the patient's encountering. Let's say a patient said, "Yeah, my doctor said 6 months ago that I have high blood pressure, but then we didn't want to start medication because he didn't consider high blood pressure." And today she is got her blood pressure is greater than that number. Then one can either talk about lifestyle modification some more or start medication, um, or both. I think the board expects they may expect you to say lifestyle modification if there's only one choice here. But if starting medication patient wants it and wants to, I think that's reasonable. But I think the boards may want you to say lifestyle modification if it's never been mentioned before. Now that said, I think the board also wants you to, when somebody's pre-hypertension, that lifestyle modification is in order. You talk to them about that, and perhaps that can prevent pre-hypertension from going into full-blown hypertension. Pre-hypertension does have a tendency to go into hypertension itself, but it the pre-hypertension is not. Hypertension is further broken down into stage one and stage two. Stage the key number there is 160 over 100. 160 over 100 or above stage two. 160 over 100 and above stage two. Less than that, but obviously abnormal, stage one. Now, if either systolic or diastolic is in one foot in one foot in the other, the foot in the higher stage will be used for categorizing. There's a concept of hypertensive urgency and hypertensive emergency. Hypertensive urgency refers to hypertension. Severe hypertensive urgency refers to severe hypertension without end organ dysfunction, whereas hypertensive emergency is severe hypertension with organ dysfunction. Hypertension is more prevalent in the African American population, who at the time of diagnosis has a higher incidence of um, end organ dysfunction. There is a graduated relationship between hypertension and strokes, MI, heart failure, and ESRD. That is that the treatment of hypertension, lowering blood pressure, does improve that, and it seems to correlate one with the other. And if we look at the blood pressure and its uh, complication rate, lower than 50 age years of age, um, diastolic blood pressure seems to correlate better with outcome. Whereas older than 50, the systolic blood pressure seems to be more predictive of outcome. More than 90% of the patients at time of diagnosis do not have an identifiable cause. These are referred to as essential hypertension. So most people are essential hypertension, and there are some a group of uh, patients that have identifiable cause. For example, aldosteronism. Blood pressure is a product of peripheral resistance times cardiac output. There are some patients that are considered salt sensitive, meaning that restriction of salt would improve their blood pressure control. Most patients with hypertension are asymptomatic. So it is not correct to accept the explanation. Oh, since I don't have heart symptoms, I don't need medication. That's not right. The bladder of the cuff should circumference the arm between 80 and 100%. It should be more than 80%, but should not overlap it. Blood pressure reading should be done after a patient sits quietly. Blood pressure reading should be done in both arms. The higher of the two is supposed to be used. If they ever ask you which method is to be used, the oscillatory or the oscillometric uh, method, choose the oscillometric because it senses the change in blood pressure itself as opposed to the objective reading of the observer. And if one's systolic pressure is greater than 180, it's reasonable to go ahead and start patient on medication right then. And in the elderly patient, uh, suspecting of maybe there's orthostatic hypotension, a stand-up reading is to be read.